This is a training module for caregivers of individuals with Down syndrome. As we progress into the module, we will discuss how individuals with Down syndrome are susceptible to Alzheimer's disease, and because of this, we'll provide additional information and training to those who act as caregivers. First, I'd like to introduce myself. My name is Megan Saunders. I'm currently in the Adult Geriatric Nurse Practitioner program at the University of Vermont. For my final project, I've chosen to provide education and training to people who work with individuals who have Down syndrome and may develop Alzheimer's. A lot of times, people who work with this specific population are either trained in one or the other, but I'd like to highlight the co-diagnoses and things involved with that. The goals of this training module are to provide caregivers a better understanding of people with Down syndrome, especially with the added diagnosis of Alzheimer's disease, and what types of features present, what impact this has on the care you're providing, and some anticipatory guidance of what's to come down the line. Towards the end of the module, there are specific examples of possible behaviors that manifest with Alzheimer's disease and how staff can respond to the adult with Down syndrome who is exhibiting such behaviors. Before we get started, I'd like to bring everyone's attention to the concept of person-first language. Some of you may have already heard this, or some of you may be hearing it for the first time. Person-first language allows for an individual to be recognized first as who they are, and all other characteristics to be secondary. By doing this, we are emphasizing the person, not the disability. A disability is something that someone has, but doesn't define who they are. It's crucial that we are mindful that the language we use when talking about people with disabilities not only has an impact on the people we're speaking to, but most importantly has an impact on the person with the disability. Something I hear all the time is, "Oh, I love Down's people." And now I know people don't mean any harm by this, but they're really putting the disability before the individual. What they could say is, "I love people with Down syndrome." The same goes with examples such as the autistic child or the wheelchair-bound man. We want to put the person first. Seen on a big picture level, if we all start incorporating person-first language into our daily communication, we make a positive contribution to people with disabilities in offering them the respect they deserve, which translates into higher self-esteem and self-determination. Now we can get into some of the specifics of Down syndrome, including how it is defined, common medical problems found in this population, life expectancy, and the concept of quality of life. So what exactly is Down syndrome? Down syndrome is extremely common and occurs as frequently as 1 in 700 births in the United States. It is a developmental disability that occurs when there are genetic changes resulting in a third copy of chromosome 21, when other people have just 2 copies. Because of this extra copy, there are certain conditions that people with Down syndrome are more susceptible to. There are certain physical characteristics that are common to people with Down syndrome, including low muscle tone, small stature, slanted almond-shaped eyes, and lower set ears. Although these are commonalities, each person with Down syndrome is a unique individual with their own set of talents and quirks. And while some people with Down syndrome may only have a few of the characteristics, others may have all of the characteristics. There's often a simian crease, which is a line across the inner palm on their hand, as well as a gap between their first and second toes of their feet. There's a concept of accelerated aging that occurs in adults with Down syndrome, meaning they experience certain conditions and physical features that are common to typically aging adults at an earlier age than the general population. Although this is not fully understood, a lot has to do with that extra copy of chromosome 21. Generally, this acceleration can be seen medically, physically, and functionally. Many families and caregivers say there is a noticeable slowing down in their 40s and 50s of their loved one with Down syndrome. So here are some examples of those physical characteristics. On the left, you can see the lower set ears, as well as the more flat facial profile. In the center is an example of the simian crease, that line across the palm. And on the upper right, you can see the almond-shaped eyes. Here's a list of some of the most common medical problems that occur in people with Down syndrome. I'll highlight a few so we can get an overall idea, and then we'll focus on Alzheimer's disease. Looking at thyroid disease. So studies indicate that hypothyroidism occurs more frequently in people with Down syndrome than it does in the general population. Untreated, this looks like mental sluggishness, fatigue, weight gain, and irritability. Looking down to atlantoaxial instability, this has to do with weakness in the neck as determined by X-ray. So when the X-ray shows that there is a specific amount of space between the first and second vertebrae, there are restrictions placed on specific sports. So anything that you would need a strong neck for, basketball, football, they would be restricted. Sleep apnea is a common disorder in which you have one or more pauses in breathing while you sleep. It's estimated that the majority of people with Down syndrome do have sleep apnea, mostly related to their anatomy, such as low muscle tone in the mouth and upper airway, poor coordination of airway movements, narrowed air passages, and a large tongue. Sleep-disordered breathing has been shown to affect cognitive abilities and behavior, as well as respiratory and cardiac effects. Symptoms that are suggestive of sleep abnormalities include restless sleep, snoring, gasping noises, heavy breathing, frequent waking during the night, and daytime sleepiness. Sleep apnea can also cause behavioral changes such as irritability, poor concentration, and impaired attention. Let's move on to some other medical problems common to people with Down syndrome. Congenital heart defects are very common to people with Down syndrome, usually found as an infant or child. As you can see on this slide, 40 to 50% of people with Down syndrome are born with a heart defect. It's now common practice to screen for such abnormalities when a fetus or infant is diagnosed with Down syndrome. Typically, most defects can be corrected surgically once they're detected. The most common of the defects include the atrial septal defect and the ventricular septal defect. Symptoms with such defects include fatigue, sweating, racing heart or a fast pulse, and shortness of breath. Another common medical problem found in people with Down syndrome is arthritis. And this is a difficult one because oftentimes people with Down syndrome don't complain about being in pain, or they don't know how to describe it, so they don't bring it to anyone's attention. People with Down syndrome are typically hyperflexible. Over the years, they can put increased wear and tear on their large joints, such as their hips or knees, and this leads to increased risk of osteoarthritis. Much like in the general population, adults with Down syndrome who are overweight or previously overweight are at an increased risk. Arthritis is painful and can lead to decreased mobility and decreased willingness to participate in activities. For some individuals, the pain can express itself through negative behavioral changes. Untreated pain increases the risk of further immobility and deconditioning due to the reluctance to participate in such activities. So what can we do? Let's pay attention to changes in walking or activity level, looking for signs of stiffness or discomfort. And let's keep in mind that many adults with Down syndrome may underreport pain or appear to have a high pain tolerance. If pain is suspected, discuss the possibility of underlying arthritis with the primary care provider. Let's bring our attention to aging in people with Down syndrome and what that looks like. No longer are people with Down syndrome dying at a young age as they did a few decades ago. With the increase in screening, technology, and accommodations, individuals with Down syndrome are living well into their 50s and 60s, and even 70s. Many of the things that contribute to a quality of life in the general population do the same for those with Down syndrome. Obviously, it's individual specific, meaning that everyone enjoys their own hobbies, social circle, and perceives themselves uniquely. Individuals need freedom of choice and need to have a feeling of independence and having some control over their life in order for this ideal to be achieved. Many times it is the caregiver or staff member that has the ability to empower an adult with Down syndrome to accomplish their dreams and achieve their goals, contributing to a positive quality of life. Numerous studies indicate the importance of aging in place. This concept, as you may have heard before, supports the idea of having the supports come to the individual rather than the other way around. In order for aging in place to succeed, there are some factors that must be accessible, including caregiver training, increased staff, creating a calm, safe environment, and making sure that the family and individual are at the center of all decisions being made. Despite the genetic pathway that is established in people with Down syndrome and the effects of the third copy of chromosome 21, we shouldn't be blind to the interactive nature of intervention and environment. Having Alzheimer's disease does not mean that quality of life is unobtainable. One particular study examined factors that contribute to quality of life, and they found the following characteristics to be of greatest importance: pain-free health maintenance, psychosocial well-being, skill maintenance support, involvement of family and friends, environmental support, and even relief of caregiver burden. Dementia is an umbrella term for signs of cognitive decline that have an effect on daily functioning. Under the umbrella of dementia-type behaviors are several diagnoses, one of which is Alzheimer's disease. Although Alzheimer's disease can only be officially diagnosed post-mortem, it is assumed that this is the form of dementia experienced by those with Down syndrome due to that genetic connection on the 21st chromosome. To further differentiate between dementia and Alzheimer's disease, dementia describes a group of symptoms, memory loss, behavior changes, personality changes, that are severe enough to interfere with normal daily activities. Many different things can cause dementia. Alzheimer's, on the other hand, is the most common type of dementia. It is not a normal part of aging. It's a physical disease of the brain that results in impaired memory, thinking, and behavior. It is a terminal illness and will ultimately cause death. Let's take a closer look at the connection between Down syndrome and Alzheimer's disease. Chromosome 21 plays a key role in the relationship between the two, as it carries a gene that produces one of the key proteins involved with changes in the brain caused by Alzheimer's, called amyloid precursor protein. These changes affect brain function and ultimately destroy the brain's ability for normal processing. The average prevalence of Alzheimer's disease in Down syndrome is around 15% for an individual in their 40s. This increases with age and can be as high as 25.6% at age 60, depending hugely on the choice of diagnostic instruments and criteria employed. This is compared to about 5% prevalence of Alzheimer's disease in the general population of those age 60 and higher. While Alzheimer's disease in Down syndrome is frequent, it is not inevitable. The pre-diagnosis stage includes everything up to the point of Alzheimer's disease, if it does indeed develop. Health maintenance, such as regular healthcare provider visits, dental and vision exams, are all recommended as they are with the general population. Because of the higher incidence of Alzheimer's disease in people with Down syndrome, it is important to be aware of changes that may indicate that Alzheimer's disease might be developing, as well as to be aware of other conditions that may mimic the signs of Alzheimer's disease, such as depression, pain, sleep disorder, or hypothyroidism. Caregivers are usually the first to notice a difference in the individual with Down syndrome, and that is why this training is so important. The most important thing that can be taken away from this module is the idea of knowing an individual's baseline and recognizing changes while bringing them to the attention of parents, guardians, or healthcare providers. There are guidelines which outline some of the ways in which we can track changes and note developments of people with Down syndrome, such as comparing current functional level with baseline, noting dysfunctions that are common with age versus possible emerging dementia, awareness of medications, as well as their possible side effects. Noting other destabilizing influences on an individual's life, such as family leaving, death of a loved one, constant turnover of caregivers. All of these things could bring on irritability or depression, which also mimics signs of Alzheimer's disease. I want to bring to your attention the concept of an individual's baseline. This term describes how someone functions emotionally, physically, and cognitively as their normal day-to-day, and also indicates pre-diagnosis when used in this context. In the general population, for an individual that is developing Alzheimer's disease, we may notice the first changes in baseline concerning their memory and orientation. So say someone goes to the same grocery store every week, and for some reason on this particular day, they get lost on their way home. For individuals with Down syndrome, however, this change from baseline comes about a bit differently. As shown on the slide, these changes are most often stemming from changes in their prefrontal lobe that manifest as characteristics of indifference, uncooperative nature, depression, and socially inappropriate or deficient communication. Other changes that may occur: confusion with familiar tasks or in a familiar situation, increased frustration or loss of patience, or changes in personality. Maybe the individual used to laugh frequently and always impersonate a certain comedian, but now seems to have stopped enjoying that. Another difficulty in determining a change from baseline is the discrepancy of screening people with Down syndrome for Alzheimer's disease. We will get into the details of this in a few slides. However, the takeaway point is that as a caregiver, you are the one who is able to recognize an individual's baseline and any changes that appear to be permanent. So let's run with the idea that you did notice a change in the person you provide care for. You're not sure if it's significant, or maybe it's a disruptive change that very obviously needs to be addressed. What should you do? It is important for you to realize that you are not alone in tracking this. You are part of a collaborative team and can reach out to others that provide care for this person as well. For starters, the individual's family or guardian may be a good resource to check in with. Has this ever happened before? Do they notice a change as well? Have they started any new medications recently? Have there been any recent injuries? If it is clear that a change has occurred, now would be a good time to make an appointment with the primary care provider. This individual will head the effort in investigating what changes are happening and the reasoning behind it. Although they may possess more knowledge about some of the biological processes happening, you are a valued team member because you spend the most amount of time with the individual. If the changes do in fact indicate Alzheimer's disease may be developing, proper assessment will occur through special tests that evaluate memory, decision-making, and processing. There are special screening tools that can assist a provider in coming to an official diagnosis of Alzheimer's disease. One of the more difficult aspects of diagnosis of Alzheimer's disease in individuals with Down syndrome, as I alluded to earlier, was the concept of a baseline. Not only do individuals with Down syndrome have a different functional baseline than individuals without Down syndrome, but this is not reflected in general screening tests. There are some tests that are geared towards individuals with intellectual disabilities, and the most important thing to take away from this is that the initial screening is done early enough to get an idea of their actual baseline, as well as the same screening test be used to evaluate any changes. By doing this, you're making the greatest impact to properly assess changes that are occurring over time. Additionally, these tests may indicate that changes happening are actually attributed to another medical change such as hypothyroidism or depression. There are 3 stages in the progression of Alzheimer's disease. They are early, mid, and late stage. These stages represent general symptoms that present in an individual with Alzheimer's disease, although there is a gradual, seamless transition from one stage to the next. It is important to understand that although the process cannot be stopped, as caregivers of individuals with Down syndrome and Alzheimer's disease, we can be prepared. Taking a proactive versus reactive approach to the changes that are occurring or will most likely occur. When we can anticipate these changes and are knowledgeable about what resources we have available to us, we increase the chances of having positive outcomes. Generally, the early stage can last anywhere from 5 to 8 years. Common signs and symptoms can include a subtle shift in their personality or ability to carry on things they had previously enjoyed. Communication may begin to change through word-finding problems. Often, stage 1 is characterized by personality changes. Maybe the individual is starting to show anxiety when previously they had not had any. They also may show difficulty with conversation. The important thing here is to stay ahead of the disease process through education, reaching out to team members to make sure everyone understands what's happening, what changes are occurring, and what that means in terms of supports for now and in the future. Undoubtedly, supports are going to change as well as increase. For example, an individual may at baseline only need prompting and general supervision, but with the progression of the disease, may start to need more routine prompts for toileting, self-cares, redirection, or orienting reminders. So what can we do during this first stage? Important factors are to help the individual maintain their skills. If they can use their iPod, microwave dinner, or navigate the computer independently, we want to help them keep up those skills. At this time, it's also important to start streamlining their routines. Caregivers should start anticipating that there are going to be difficulties with transitions as the disease progresses and they become more confused. Routines of daily activities such as dressing, toileting, meals, or activities should be outlined in a format conducive to the individual. So whether they use an iPad, large calendar, or pictures on a whiteboard, whatever works best for them. It's also important to keep in mind that people with Down syndrome learn very well with visual cues and repetition. So relying on pictures for their schedule is often more successful than just reminding them verbally. In addition to streamlining routines, you can also consider making necessary adaptations so that they can continue to have community involvement and participate in activities that they enjoy. Another thing to consider during stage 1 is how communication is changing. Depending on the progression of the disease in the individual, it's often necessary to begin to simplify your conversation in a respectful way using simple and direct language. and make sure you give ample time for responses and do not fill in words when they experience difficulty. The mid-stage generally lasts between 1 and 5 years. Common signs and symptoms include progressive memory loss and loss of recognition of some family members and caregivers. This loss comes and goes, and like all of these symptoms, some days can be better than others. This stage is also where some behavioral challenges develop, particularly agitation, restlessness, and pacing. This can manifest itself in many behaviors, such as yelling out, hitting, running off, or refusal to participate in activities they once enjoyed. Another prominent behavior that comes out during this stage is repetitive talk or questions. During this time, some negative behaviors may stop or change, and it's always important to notice if this is in relation to any changes that are happening in the individual's life, such as a new medication, stopping a medication, a new living situation or roommate, a new caregiver or loss of a caregiver. Any major changes should be assessed for a possible correlation to a behavior. There will continue to be the need for increased supports, primarily in supervision for safety, as well as in personal cares. Incontinence can become very problematic and challenging for both the individual and the caregiver at this time. What response works one day may not work the next, so having a different approach or two in your toolbox can serve you well. So what are some of the things we may need to do for the individual in the second stage? Supervision is certainly going to be increased for safety purposes, not only outside of the home around traffic, but inside of the home as well, specifically in the kitchen to protect from burns, knives, dropping heavy things, etc. Strategies for proactive management of behaviors, such as change in a sleep pattern, resistance to bathing, or expressions of heightened anxiety, include such things as massage therapy, soft music, or even aromatherapy. Communication continues to transform during this stage, and it's important for our observation skills to be intact, watching the individual for any signs of pain, changes in ability to swallow, sleep, or eat. Activities that interest the individual and hold their attention may change as well, so changing the activities to games that orient them, such as rehearsing the season, day of the week, their name, are great practices, as well as reviewing photos of loved ones and even scrapbooking family and friend photos can be reinforcing. If there is trouble during mealtime with choking, one way to increase their freedom and independence is to offer easily eaten finger foods and ensuring that difficult foods such as steak are cut into small pieces. Stage 3 is also known as late stage or end stage Alzheimer's disease. This stage typically lasts between 1 and 3 years for individuals with Down syndrome and tends to be the briefest. During this time, the disease has changed the individual significantly, and there's going to need to be a lot of shifting of supports to accommodate their Alzheimer's disease and increased medical needs. Some of the changes include decreased mobility or balance, meaning they're more prone to injuries such as falling or slipping downstairs. Other difficulties may arise that could include seizures, inability to swallow, breathing problems, or no longer being able to do any of their self-cares. This is a very difficult time, especially for caregivers and family in supporting their loved one through this last leg of their journey. End-of-life planning should begin at the time of diagnosis to ensure that everyone is working collectively toward the same goals. Ideally, the individual should be involved in the planning to the extent that is appropriate and that they wish to be. At this end stage, it's possible that the individual needs to be moved to a nursing home or an establishment that can provide for their increased medical needs. Care is often necessary around the clock, and many families or caregivers are no longer able to provide this themselves. By this time, the individual may need to be transferred to a different facility, or they may be able to have appropriate supports which enable them to spend the late stage in their current residence. Additional training may be required of medical equipment such as wheelchair use, oxygen tanks, or Hoyer lifts. Preserving communication is very important during this stage. There is evidence that many individuals are able to understand more than they can express, so efforts at communication by staff and family members are still important. For example, talking even if there is no response, using touch, responding positively to any sound the person makes as an effort to communicate, and always saying goodbye when it's time to leave their presence. Like in previous stages, Observational skills are key in identifying if the individual is in distress and preventing complications such as skin breakdown through frequent position changes, cleaning up from incontinence promptly, and maintaining hydration and nutrition. The end stage does ultimately cause death, but it is the moments and planning leading up to this stage that can bring about a positive death experience. Now let's shift our focus from the stages of Alzheimer's disease in people with Down syndrome to some of the issues that come up frequently when caring for these individuals. The ability to communicate will transform through the disease process. Nonverbal communication is critical, and individuals with Alzheimer's rely on emotional cues and body language to interpret what is being said to them. This is important to remember if you happen to be frustrated or upset, but are trying to relay information to the individual that's unrelated. They will receive mixed signals and are unable to process the conversation because what is being said does not match the emotional content. Ultimately, as a caregiver, you want to relay a safe, calm environment. This enables the individual to feel most comfortable. It's important to avoid words such as no, stop, or don't, and instead change the statement to reflect positive language. For example, if you want them to stop tapping their spoon loudly on the plate, say something that will either distract them or bring attention to something different, such as, "Oh wow, John, look at that sunshine outside," instead of telling them to stop tapping. It's also important to look for the emotion behind what the individual is saying or expressing and connect there. Listed are some techniques for you to try and what to avoid when speaking with an individual with Down syndrome and Alzheimer's disease. Other techniques include avoiding open-ended questions, but still giving a choice between two options. So instead of saying, "What do you want for dinner?" saying, "Do you want chicken or pasta for dinner?" Now let's turn our attention to some of the behavioral challenges that may come up as the disease progresses. I think it's important to remember that behavior is a form of communication. And when you think of it that way, we can more easily see what the individual is trying to say rather than just viewing the behavior as a problem. We know that common behaviors include aggression, agitation, confusion, repetition, trouble sleeping, or wandering. Initially, we should have the same response to all of these behaviors, and that is to try to find the trigger. For example, are they unable to say what they're thinking, so they hit because they're frustrated? Or are they in pain and it causes them to yell? Although it's not always clear what these behaviors mean, these behaviors may pose a threat to an individual or others. Common modifications include providing reassurance and, if appropriate, a gentle touch, use of redirection techniques or distraction. Keep in mind, though, that different approaches work at different times, so be patient and flexible. Let's break these behaviors down by how we should respond to them. Keep in mind that while these behaviors are an attempt at communication, we need to ensure the safety of the individual, ourselves, and others nearby. In the case of aggression, pain needs to be investigated as a possible source of the behavior. If pain does not appear to be the culprit, then we move on to focus on the individual's feelings instead of their actions or the facts of the situation. Help them identify their possible feelings by stating something like, "Mark, you seem frustrated." Further, keep the situation in check by trying to limit distractions and then shift the focus to another activity if possible. Again, anxiety or agitation could be related to pain, so do your due diligence in making sure that it's not what's going on. Listen to the individual's concern or frustration while providing reassurance. Try not to talk at the person, but truly listen. Depending on the problem, it may be a simple fix of redirecting the individual to a more constructive activity, or it's possible the environment can be modified to help the situation. If this is an individual that appears to have a lot of pent-up energy that is fueling their anxiety or agitation, try to find a physical activity that can be done safely while encouraging them to engage in something positive. Repetition can be more of an annoyance than anything else. Oftentimes, people with Down syndrome and Alzheimer's disease can become fixated or stuck on a word, phrase, or action. This may be seemingly random, or it may be caused by either seeing someone or something, a specific time of day or activity, or even triggered by someone saying or asking something. It's helpful to assess the emotion behind what's being repeated. So do they seem anxious, upset, or happy? Does the repetition calm or soothe them? Sometimes you can even turn the repetition into a positive activity. Maybe the individual likes to rub their hands across the table or wall when they're walking. You can ask them to help you keep things tidy and give them a cloth so they can dust. This turns the behavior into a positive, and you can offer praise and reinforce their contributions. You may run into a repetitive question that becomes problematic in terms of preventing the person from accomplishing anything else. If they get stuck on a certain question, for example, what's today, or will I see Sue today, it can be helpful to provide a memory aid, for example, a weekly calendar with Sue's name on Wednesday. Wandering is more of a safety issue than anything else. There are devices that can be installed, such as WanderGuard or similar manufacturers that require installation in the home and wearing of a bracelet on the individual. Another easy device for families to use is putting in a motion detection unit, such as used for pool areas, that can notify the caregiver that someone is up and about, say for example in the living room, or they've opened the back door to the deck. Also, locks can be installed on the tops of front or side doors to prevent wandering outside without supervision. This may seem controlling, but the individual could be seriously hurt, if not fatally, if they were to wander outside without the knowledge of their caregiver. Aside from the troubles of sleep apnea for many individuals with Down syndrome, Alzheimer's disease offers a new spectrum of sleeping difficulties as the disease progresses. Oftentimes, the individual's circadian rhythm becomes dysregulated, causing them to be awake at night and tired during the day. This causes a strain on family members and caregivers alike. This can be something that is prepared for, though, and possibly prevented if a routine is maintained and certain sleep hygiene processes are followed. So, at nighttime, help the individual prepare for bed by creating a calm, quiet environment, lowering the lights, and keeping stimulation low. Turn off televisions, use calm voices, etc. Avoid any stimulants such as caffeinated soda or chocolate near bedtime. Help them to be physically active in the daytime to cause appropriate fatigue in the evenings. And if there are deeper disturbances and the individual is not helped by any of these suggestions, it's important to bring them up to the primary care provider's attention. Now that we've discussed Down syndrome, how Alzheimer's disease presents in these specific individuals, and some of the behavioral aspects of the progression of the disease, I want to leave you with some key points. The first being that caregivers are truly the first line in noticing changes in the individual with Down syndrome that may indicate signs of Alzheimer's disease. Key changes include behavior or emotional changes, difficulty communicating, and just no longer being the person that they once were. And these are all indicative of maybe it's Alzheimer's, maybe it's something else, but this person needs to be assessed. So truly, the responsibility lies on the caregiver because you spend the most time with the individual. So where are our resources for caregivers? There are some national organizations. This first link here is from the National Task Group, and it provides a question and answer format for information about dementia and disabilities. The second is the National Down Syndrome Society. That is a wonderful resource for all things having to do with Down syndrome. I highly recommend checking it out. The last is the Alzheimer's Association, and they do have a print-off topic sheet about Down syndrome and Alzheimer's disease, specifically for if you needed to hand out some basic information to save family, friends, or other caregivers. Locally, there isn't a whole lot that has to do with Down syndrome and Alzheimer's disease. We do have the Vermont chapter of the Alzheimer's Association, and on their website, they do have a link for the statewide dementia plan for Vermont, although that is more Alzheimer's related than Down syndrome. Below is the Champlain Valley Down Syndrome Group. Again, that's more Down syndrome than Alzheimer's, but it's a great resource for connecting people with Down syndrome. And lastly, the Howard Center Developmental Services has their website on how to link people who need community supports. Lastly, you can email me at that UVM web address, and I'd be happy to answer any questions you have related to Down syndrome and Alzheimer's disease. Well, this concludes the training module. I put some pictures up of myself with my brother Matt, who has Down syndrome, and I think that it goes without saying that he provides the inspiration behind this training module to further our education on caring for people with Down syndrome. I did put up a link, and in order to receive credit for completion of this training module, just go ahead and take that post-test survey. It's a quick 10 questions, and it won't take much time at all. Thank you.